Hello, my name is Alyssa Sheehan and I am a nursing student. I'm going to be presenting a patient to you. Patient is an 83-year-old married Caucasian male. His former job was as an engineer, but he is now retired. At this time, patient's chief complaint is of his rheumatoid arthritis. He was first diagnosed with arthritis at age 79 and first noticed symptoms when he experienced myalgia and weakness in his shoulder when he tried to lift his arms up. He gradually began to lose the use of his fingers. Patient reports an aching pain in his knees and difficulty when standing. He rates his pain at an 8 out of 10. He describes the swelling and stiffness in his joints as debilitating and has very little use of the joints in his hands and toes. Because of this lack of dexterity, he is not able to do many of the activities he previously enjoyed. He has trouble performing his activities of daily living. The patient uses pharmacological interventions to help with the swelling in his joints and also takes Tylenol as a sleep aid for his pain. An associated symptom includes an ulcer on the second toe of his right foot, which was a result of the deformity in his toes. He was given a spacer with a hole in it that he claims helped the ulcer. Other associated symptoms include pruritus and some loss of balance, but this may be age-related. The most pertinent part of the problem, according to the patient, is the loss of function when performing some of his activities of daily living. Patient's vital signs are stable. Blood pressure, 108/72, heart rate, 86, respirations, 24, temperature, 34.6 degrees Celsius taken orally. Past medical history: chronic obstructive pulmonary disorder, pneumonia, pulmonary edema, cataracts, and rheumatoid arthritis. All immunizations are up to date. No known drug allergies. Past hospitalizations and surgery. Patient was hospitalized in February 2015 for pneumonia and in 1970 for pulmonary edema. Cataract surgery for both eyes in 2012. Surgery was performed because of his impaired night vision. Patient states that blurry vision when he is not wearing his glasses has developed since the surgery. Patient is on numerous medications for joint inflammation, eye pressure, nocturia, pruritus, iron deficiency, and myocardial infarction prevention. He also takes Symbicort twice a day for his emphysema and has Combivent as an emergency inhaler, which he uses occasionally. Functional assessment. Patient denies current tobacco and illicit drug use. However, he does say that he used to smoke heavily. He reports light use of alcohol about once a week. Patient denies regular exercise regimen. He reports drinking soda and also about 3 cups of coffee a day. Patient states that his sleep patterns lately have been poor. He thinks the reason for his disrupted sleep may be nocturia, and he does report taking short naps throughout the day. Patient states that his diet is normal. He uses a walker to move around the house because of pain in his knees, and he also wears glasses. Psychosocial. Patient currently lives with his wife and 2 sons in their home in Southgate, Michigan. He states that his wife is his biggest support system. He has 5 children and 7 grandchildren and feels close with them. Patient had 7 brothers and 2 sisters, but none are still living, including his parents. He does not report having self-esteem issues, and he describes himself as quiet and reserved. Hobbies and coping mechanisms include watching television, doing crosswords, being a member of the Knights of Columbus, and attending church. Patient does not report any environmental hazards, but claims that one of the current stressors in his life is his lack of sleep due to his disrupted sleeping patterns. Patient and his wife are spiritual, identify as Catholic, and attend church once a week. His level of education is a master's degree in math. Patient reports visiting his doctor every 6 weeks for regular checkups. Family history. Several of the patient's brothers died of cancer, one of them being colon cancer. Patient's father died of heart problems, and he has an aunt who has severe arthritis. Musculoskeletal. Given that the patient has severe rheumatoid arthritis and that it has a major impact on his daily life, it is important to assess his musculoskeletal system. Patient denies any redness or warmth in his joints, but does report swelling and occasional pain in the knees and arms. Patient also denies any broken bones, paralysis, or tremors. He also reports some deformity in his hands and toes, where his toes have curled down and moved together, particularly in his right foot. Patient states that there are severe limitations to his range of motion in the hands. He is only able to independently move his pointer finger in both hands. He reports that because of this, he is very limited in performing his activities of daily living, such as gripping objects and driving. Patient reports occasional weakness in his knees. Upon examination, it is noted that patient has decreased muscle mass, but bone structure appears normal. Slight kyphosis was observed, and he shuffles slightly when he walks. Patient also has some issues with balance. Patient is not able to perform hand grasps because of the swelling and deformity in his hands and fingers. Muscle strength was 5 out of 5 in bilateral upper and lower extremities. Decreased range of motion observed in neck and spine, and particularly in fingers and toes. Patient had difficulty performing right and left lateral movement in the neck joint and flexion of the spine. Patient cannot perform flexion, extension, or abduction bilaterally in his fingers and was only able to perform opposition bilaterally with the pointer finger. Rheumatoid nodules noted in bilateral hands. No edema present. Respiratory. Given that the patient has emphysema, it is important to assess his respiratory system for function. Patient reports shortness of breath upon exertion, but states that he does not usually need to use an inhaler. The highest level of activity he is able to perform without shortness of breath is going up and down stairs. Patient denies history of bronchitis and asthma, but has been hospitalized for pneumonia before. He also reports a previous habit of heavy smoking, but has since quit. Patient reports occasional coughing but denies sputum production and frequent upper respiratory infections. He reports occasional pain and wheezing with breathing. Upon examination, thorax appears normal for color and symmetry. Anterior-posterior diameter is increased, resulting in a barrel chest. Slight tachypnea observed and some distress noted when breathing. Extra muscles around the clavicle are used when breathing. Trachea is midline and posterior expansion was palpated, although it was slightly decreased. Increased tactile fremitus felt on the posterior right side of thorax. Upon palpation of posterior ribs and thorax, no masses, lumps, tenderness, cracks, or crepitus were felt. When auscultating the anterior lung field, some wheezing and rhonchi were heard in the bronchial area, and some crackles were heard in the right vesicular area. When auscultating the posterior lung fields, slight wheezing and whooshing were heard in the right vesicular area. Bronchophony and egophony were found on the right side around the 6th and 7th ribs. Nothing was found when testing for whispered pectoriliqui. Pertinent system number 1, cardiovascular. Patient has a history of smoking and his father died of cardiovascular problems. A 2014 article in the American Heart Association Journal analyzed the effects of smoking on cardiovascular disease. Studies found that cigarette smoking was responsible for 10% of cardiovascular diseases. The main reason is that smoking causes atherogenesis through endothelial damage, increase in proatherogenic lipids, decrease of high-density lipoprotein, and induction of inflammation. They conclude that more research needs to be done to increase the understanding of health damage caused by smoking, develop markers for smoke exposure, and to develop better therapies for cardiovascular diseases caused by smoking. Given the patient's history of long-term smoking, it is important to assess the function of his cardiovascular system. Even though he has quit smoking, he would still benefit from information about the damage smoking causes and possible therapies that are available. Pertinent system number 2, integumentary. Patient had a pressure ulcer on his right foot between 2 of his toes due to the inability to move his toes very much. Patient also has thin skin, aging spots throughout his body, and reports bruising easily. Considering all of this, it would be important to perform an integumentary assessment. According to an article published by the Journal of Gerontological Nursing, risk factors for pressure ulcer formation include immobility and inactivity, age, malnutrition, fecal and urinary incontinence, and a decreased level of consciousness. Given the patient's age and the decreased level of mobility in his toes and hands, this puts him at a risk for developing more pressure ulcers, so an integumentary assessment would be pertinent.